Welcome to the Catalyst Podcast. I'm your host, Charles Epstein. Joining me today is David Guth, the CEO at Centerstone, a nonprofit health system specializing in mental health and substance use disorder treatments. David, welcome.
Well, thank you, Charles, and thank you so much for having me here today.
Oh, delighted. Thanks for taking the time. I'm going to come back. I know that was a rather terse description of Centerstone, so I'll give you an opportunity to expand on that.
Sure.
You know, in preparing for this, I see that you earned a BA in mathematics from Vanderbilt that went on to get a master's in social work. So I have two questions in order of importance, of course.
Yeah, of course.
How did Vandy, suddenly become a football powerhouse? What accounts for this astonishing development? Then I'll get to my second question.
My best friend has been predicting a breakout season now for about 50 years. So, I mean, eventually,
a broken clock.
I have the foggiest idea how this happened. It's a blast, but I certainly wasn't expecting it.
Okay. So my second question, how does one go from mathematics to social work? That doesn't seem like a standard path.
I thought all math majors went into social work. I just assumed that was the. My wife always rolls her eyes when I get asked this question because she knows the story, and I wish I could tell you it was just all part of the plan, but my senior math was easy, which is why I had it, and I originally went to college with the idea I was going to be a physician, and organic chemistry changed my perspective on that. So here was my senior year, and I needed some electives, and I'd been taking a ton of psychology courses, which I found really interesting, and ended up with nearly a major in that as well. But I digress. Anyway, senior year, and a friend of mine says, "Hey, you ought to sign up for this class." She was a psychology major, and she said it's 4 hours credit for each semester, 2-semester class, and there's no paper and no exam. I was in. And the catch was you needed to apply for and get accepted at a practicum placement where you would go 1 day a week and basically work a shift in a practicum placement in behavioral health. Well, this very good friend, Pam, had a car, and she was interested in the adult services. So she was going out one day to interview for the practicum in the adult services unit. And she also said to me, "David, there's an opening in the adolescent program. You want to ride along and go for an interview?" And so I did. And long and short of this, I did the practicum. They offered me a job at just under minimum wage at the time. When I graduated, I accepted it. But another side, which you may want to cut out of the podcast, but another side is that as I was waiting for that interview, that first time I'd ever stepped inside this state hospital, I was in this drafty old building, intersection of these two massive hallways on a government-issued wooden chair, and I'm waiting for my interview, and I look across, and there's a little conference room, and I see this spectacularly beautiful woman, hair cascading over her shoulders. She doesn't let me tell this, but I noticed her legs just before I did her hair. But anyway, the point is, I just thought, that is one beautiful woman. I did not think there's the future mother of my children, but in fact, that's who that person was. So anyway, she says it sounds like I stalked her for the next couple of years, but I did not.
That's a very interesting confluence of circumstances or just coincidences.
Serendipity. Fell in love with the work, and then when they offered me that job, I didn't stay in the entry-level job for long, just a couple of months, but I fell in love with the work. I just, working with the adolescents at the state hospital, it felt like coming home is where I was supposed to be.
Yeah, that's fascinating. So, is there any math involved in work?
I tell you what, I am a numbers person, and I'm not an accountant. I took some accounting classes, but I understand numbers, and the financial piece, the projections, the really understanding some of the business dynamics always came pretty easy. I think a math degree helped, but I'm not doing any differential equations in the work that I do.
But how about, so many conversations I have with people in the field, anytime we bring in this topic of data analytics, it's sort of a crapshoot. A lot of people are just not oriented in that way. Is that something that you've pushed, advanced, given your background with Centerstone?
Yeah, I certainly believe so, Charles. But it's right. Not everybody comes to that readily. In fact, in our field, a lot of people are sort of drawn to the work. You'll hear people complain about the fact that they had to take a statistics class, which, of course, for a math major is spring break. So, I mean, really, but on the other hand, I mean, I can't remember a date or a number to save my life. So, couldn't tell you my wife's work phone number that she had for 30 years. I have a gun were at my head. So different people have different things. But yeah, I think that sort of influenced how we've leaned into embraced data and data analytics.
Yeah, very interesting. So I mentioned I'm going to give you an opportunity to expand a little bit on what Centerstone is, what you
Yeah.
guys do. Then I'm going to want to get a little bit into your history, close to 4 decades with Centerstone. So if you would, give us a little bit more of an expansive view of what Centerstone does.
Yeah, so today, since we are now into November, today is Centerstone is the merger of both Brightli and Centerstone. We came together officially on the first, though we really began operating as one entity when we signed definitive agreements back in September. So today, I'll just describe Centerstone today. We provide services from in-home to inpatient, and pretty much everything in between on the behavioral health side, and that includes both mental health and substance use, serving traumas and so forth. We have, I think, 360 locations. Those range from clinics to residential facilities, and those span a 9-state footprint, which I can come back and elaborate on. There's a workforce of the work family, if you will, is about 10,000, a little over 10,000 strong. We also have a network of 1,600 part-time network therapists that augment our staff, and those are licensed therapists across really every state and most communities across the country. And we also provide some care to our servicemen overseas. We have 2 psychiatric residency programs, and a number of psychological and social work internships and so forth. So, in a nutshell, we've got programs from preschool to older adults. And the other thing I should add is we have a fairly large IDD service arm now, largely because of the affiliation with Brightli. Centerstone just had its toe in that in one of our states, but Brightli has had a very large presence in the IDD space. And again, we've had our toe into integrated care historically, but in terms of FQ lookalike, but with the Brightli merger comes a very large full FQ, multi-state FQ system. So we feel really good about what that does for integrated care.
And by the way, congratulations on
Thank
the
you.
merger. We're going to get to
Thank you.
that in a moment. So, as I mentioned, you've been with Centerstone for nearly 4 decades. Clearly, that's a significant span of time, and a lot of things have happened over that span of time. If you would, what are some of the more significant changes or challenges?
Yeah. Well, there's, our field, like I think every industry, has had its series of challenges. I always remind people when we talk about the challenges we have that, we're not in the cell phone business. Think about how that's changed and competition and so forth. But I'd say, we certainly went through eras where stigma was the overarching problem, and it contributed to back in the day. I remember when the first cut of anything was going to be to behavioral health services. So when we look at it today, today behavioral health is really embraced. It's embraced both at the state and federal level, bipartisan. One of the few bipartisan areas of support. Stigma is collapsing. It's still there, but it's been collapsing. And I think there's real opportunity in the behavioral health care space to do more and to really advance care in ways that I'll be happy to talk about. But challenges from staffing to NIMBY issues, not in my neighborhood or backyard. We've certainly dealt with that over the years, and there's always going to be challenges. So, well, yeah, everything I'd say from dealing with state budget crisis, Medicaid challenges. Overall, the fact that there's not been true parity and still isn't today with behavioral health funding, particularly on the commercial side. So those are all been perennial challenges.
I'd like to ask you a personal question, if I may. What in that course of time are you most proud of?
Yeah, that's an easy question for me. I'm most proud of the circumstances where I've been out in the community and wearing my pin, which I'm wearing today. And I wear that pin for a lot of reasons, but mostly for this. I've been out in the community and people have come up to me and shared how much Centerstone has meant to them, saving their life. You know, the most recent, I was at a visitation of um, a really just a great human. Jim Ayers had passed, and I was at the visitation with his family, and it was way out in a rural community, about an hour and a half out of Nashville. Just finished visiting with his wife, and was on my way over to visit with the rest of the family, and this young man, young, he was probably in his 40s, in a nice suit, was just standing there by himself, kind of helping shepherd people. And I went over to introduce myself and say hi, and we got to talking, and all of a sudden he looks down at my lapel and sees the pin. And before I know what's happening, he's got me in this embrace. He's just holding me and hugging me and whispers in my ear, "You saved my life." And I still get choked up about this, but of course, I didn't do anything. But to know that he was a veteran, had the VA had recommended that he come to us, and I won't share all of his story. That's his personal story, but he talks about the fact that we literally saved his life. And there have been so many of those over the years, standing at the deli counter, you know, at the Publix, and the person across the counter telling me how that the work at Centerstone changed her life. Getting my shoe shined at the airport, and the shoe shiner noticing the lapel pin and saying, "I'm a patient at Centerstone," and hearing that with schizophrenia, having been identified quickly by Centerstone and getting into the right care, he was an honor student at the academic magnet. And as I kept up with him, he was, he went on to go to college and graduate college and do all the things that you would want for your child. And he was crediting Centerstone for that. And again, nothing that I personally did, but to be part of an organization that supports clinical staff, provides the kind of support and education that we do, and to know that that yields life-saving benefits to the people in our community, people that both that I've met and people that I'll never know. I'm most proud of that.
That's quite a legacy, David. I know you're not trying to cover yourself with glory. It's the
No.
organization, but still, that's an amazing
Well,
legacy.
I
So
feel very
kudos.
blessed to have been part of this.
And well, you should be. So let's talk about the merger between Centerstone and Brightli, which will create the largest U.S. nonprofit behavioral health care provider with an estimated $1 billion in revenue. What prompted it, and what does this merger mean for the market?
Well, so the language I think you were maybe quoting was from the press release that it will be, but it is now actually it is done. So we are the nation's largest nonprofit provider of behavioral health, and we're top line is about 1.1 billion dollars. So it's big, but big has never been the purpose in any of the mergers, either for us or for Brightli. It's been certainly getting to scale that is part of sufficiency to create what we're looking to create. So early on, as we began our early affiliations, it was really about getting large enough that we could have the capacity to just survive all the changes. And then it was really about getting large enough that we could thrive, do the things for our staff, implement retirement programs, implement a better health plan, and place a bonding benefit for new parents and so forth. So it was about that. And as both Brightli, which has had a very similar history to Centerstone in terms of these bringing together like-minded organizations, as we came together, we were both looking for additional partners that could help us have the capabilities and the scale for visibility to really transform the field. And I know that sounds grandiose, but what drives all of us and is that there are still so many areas that where there are barriers, external barriers that get in the way of our clinicians having the ability to really translate the best science of care to the people that are seeking care. It's not the fault of the clinical staff. I mean, we've got an amazing group, as I think most organizations do. The people that are drawn to this work are amazing, but there are some significant barriers, and we had to get large enough with enough, I'll go back into the data issue, with enough credibility, not only in terms of our scale, but in terms of our capacity to transform how care is delivered in this country. So I'm happy to say more about that, Charles. But that's the fundamental thing. And we talk to our boards about this. It's like what we need to be accountable for in the coming years is not just keeping our organization financially healthy, not just good customer experience from our patients, not just good engagement scores from our staff. All that is important, and we absolutely are committed to that. But how are we breaking down the barriers nationally to actually transforming how care is delivered? That's the measurement that's going to be
Sure.
that's going to be the testament to whether this affiliation accomplished what we set out to do.
You've already sort of touched on some of these elements, but what are the success factors in a merger of this size? What makes them work or fail?
Well, in my experience, it's first of all, it's I think of them as marriages. I think that is that because we're not buying each other. We're bringing together like-minded organizations. And I think about it a lot. I have thought about it a lot like marriages. You're not looking at identical organizations. You're looking at organizations that share values, because no marriage works without that, and a common vision of what you want to achieve. So as this affiliation came about, along with others that we've been through and that Brightli's been through, the first lens that we were both looking at each other is, are these organizations that share our values? Both we and Brightli walked away from potential affiliations before this, where it became clear that there was not a shared value system. So that's one. And then the second piece, and both parties were looking at that. It's sort of interesting independently. The shorthand we've been using at this is that we're seeking to be the Mayo of behavioral health. Brightli was using that conversation internally. We were using that conversation internally. And so both leaderships and boards were approaching each other with some skepticism to go, are we really on the same journey? Are you interested in getting big just to get big? And that was the test from both sides. And it was when we realized and really became convinced that the other party was every bit as committed to not scale, but really transforming care in the way that Mayo, Cleveland, St. Jude's, MD Anderson, Mass General, Vanderbilt, Johns Hopkins, all these really incredible nonprofit healthcare systems have transformed aspects of care. That's what we're committed to do.
Tell us something about C.J. Davis, the incoming CEO.
Yeah, I got to tell you, I feel so privileged to have the opportunity to work with him on these last, not long enough. I've got a little over a year and a half before retirement now, which seems odd because when CJ and I first started talking, it's over 3 years, and the window has really been closing fast for me. But I feel privileged to have an opportunity to work with him. He's really one of the true great leaders, not only of this time, but that I've ever worked with. I'm just enormously impressed with him. And I also, I personally feel blessed for this reason. I love this organization. I love Centerstone. I love the people that have built it. I've worked with board members, with donors, with members of staff that have worked just tirelessly and brilliantly to build the organization that it is today. And at all levels of the organization. I went to a retirement celebration, not a retirement celebration, a celebration of tenure of somebody that's been with one of our legacy organizations, and now us, for 55 years. Think about that. Just got a notice of one of the first people I met when I came here, Donna Reynolds, who is retiring from finance after, I think, a 43-year career. The board members that I have been. So I think about all that, the people that I care about, other than my family, other than my close family, my Centerstone and the people that have been part of it are the ones I care most about. A long runway to know that this combined organization will be led by C.J. Davis. I just feel so blessed personally for that. I have every confidence that not only is it going to be led with integrity, personal integrity, with compassion, with brilliance. He is far smarter than I am. And also with CJ's got a hunger to make things better. He's not somebody that sits back on his laurels. And he's also an amazing team player. So he elevates the team around him. He just brings out the best in all of us. So I'm as fond as I am of CJ, I got to say he married up. His wife Shauna is an amazing person. So for the record, I want y'all to know. The Centerstone got a twofer there because she's an amazing human.
So you're going to be sticking around for at least another year and a half?
Yeah, for a year and a half. About, I'll retire June 30th of 2027. My significantly better half, Carol, my wife of now 45 years, we've been together 46. She's been
See,
retired a bit.
that's where the math comes in.
That's the number I got to remember. But she said to me 4 years ago, "You got to put a stake in the ground. I've been waiting for you to come home, and so you have to put a stake in the ground." So I gave my board 6 years notice at that point, which I thought was a fair notice. And then I've been out there on behalf of the board looking at organizations and looking at CEOs nationally, and that was part of why we came upon both Brightli and really saw the opportunity with CJ.
Great.
Yeah.
In our pre-production call, sometimes we have these pre-production calls, and they in themselves could make for a terrific podcast because we had a very, very robust, entertaining, informative pre-production call. And actually, several of these next questions came out of that. So when we spoke, we discussed the gaps between scientific best practices and community standards in behavioral healthcare. What are these gaps and how do we close them?
Yeah. Oh gosh, there's so many of them. And behavioral health is not the only one that experiences this. I can't remember dates, but I remember, gosh, it had to be maybe 15 years ago or longer that the Dartmouth study came out. And you may recall that study. And it was really highlighting the challenge with community standards of care and how much of care was based on community standards and how it lagged really the science of care, and how different care was across the country just geographically. I remember it made a big impression on me, by the way. That study, I'd say, was sort of peeled the scales away from my eyes and saw that this was certainly true in behavioral health. And we began looking at what was at that time a 17-year gap between the time that the science, the proven, not speculative, not study, but the proven science in behavioral health care was established, and when that became the community practice over much of the country. And 17 years was just unacceptable. So that's been the journey. And so let's look at it today. Let's look at where it's still broken. We know that inter-rater reliability for diagnosis in the behavioral health space is less than 50%. So, and it's complicated. And I'll come back and talk about the promise of AI in this. We know that there are enormously effective evidence-based practices that have not only been developed and proven to be effective, but independently verified. And we know that most clinicians in the field believe that they are performing those evidence-based practices. But every independent study that I've been aware of that's really looked has said there's a huge gap between the fidelity of the practice and what needs to be in terms of reaching the outcomes. We knew through the STAR-D study that happened, a number of years ago, that largest study, I think still the largest study of depression ever undertaken. We were involved in that study as we were working with Vanderbilt, which was one of the research partners in that. And the understanding in the field was that you could get 50% of the people that came to you for depression could get some relief from the therapies that were provided. That was what was happening in the communities. The STAR-D study said that 80 to 85% of people, regardless of severity, could be in complete remission given the treatments that were available. And that must have been 15 years ago. Mm-hmm. So it's everything from access issues, reimbursement issues, regulatory burdens that don't create value in some of our states, the intake forms that the state may require. Whether you are a Medicaid or state-funded patient or not, can run most of that first session because it's required when you think that the person's coming to you for help not to fill out state forms. So regulatory burdens, financial burdens, staffing issues, and then diagnostic challenges, and then the fact that you've got these fidelity challenges with the best practices. Then on sort of the final pipeline into the field, you've got this enormous noise around emerging best practice. This is something else. This is why we actually launched our institute. We used to call it the Research Institute, but it's now the Institute for Innovation in Clinical Excellence, and we just call it the Institute because that title's too long. But the purpose of that institute is to decipher all that noise, really identify what is the proven best practice in the science of practice today, and what are those strategies to assist in the adoption of that. So a lot that can be improved. And, you think of and I'd say to any of the listeners, think about their own personal circle of friends and family and how many people they know that bounced off of provider after provider 4 or 5 times before they found one that connected and actually provided them care that brought benefit. But how many people they know that gave up on that journey? And so we could blame the therapists that were involved in that, but what I know is that therapists get into this for the right reasons. They need the support and the tools to provide better care. So we've done a lot of things. We've launched comprehensive simulation training that measures fidelity and has a quality assurance element that actually measures in real time therapists' actual interaction with patients. So we can talk more about that.
Yeah, no, that was the exact next question. I wanted to ask you about your partnership with Listen, a company that developed AI-powered simulation training. So how does that work?
Yeah, so short story on that is we started doing simulation with standardized patients, actors that were trained to present. Not scalable, enormously expensive, really difficult for therapists to schedule their time around. So we went looking, and we said, certainly there's a company out there, and there are a couple, but Listen was the one that caught our attention. A group of really smart, committed, well-respected psychologists that were also teaching in well-respected academia programs came together to develop simulation training using AI, and not open source AI, using really carefully curated AI that I think of it being raised in an environment around really smart, very knowledgeable clinical psychologists that were very steeped in the practice of the evidence-based practices. They developed a series of trainings that are very elegant. They break down each of the evidence-based practices into the sub-skills that have to be trained. And then they create simulation environments where clinicians not only learn those skills, but get to practice those skills as they build competency in each of the skills required for the evidence-based practice and get evaluated based on how they apply them in the simulation settings. Then the same AI technology, Listen, is ambient listening inside the actual therapy sessions and can provide the therapist after the session, can provide them feedback on how well they did and what opportunities maybe they could have used to implement some of those skills better. What we know is that these evidence-based practices work best when they're about 85% fidelity and not 100%. And this gets into some maybe additional questions, follow up on this. But
yes, I wanted to ask you. Yeah, exactly. You're anticipating the next question, but go ahead.
yeah, so it turns out that people that are 100% fidelity are just being robots. They're so focused on the protocol that they're not zigging and zagging based on what the client's presentation is. And it's like driving a car. I suspect that you and I are 100% proficient in the operation of a motor vehicle and traffic laws and signals and so forth. But we're going to zing and zag from that when the circumstances require it. If a kid runs out chasing a ball, you and I are going to drive through the yard of the person, even if we have to go through a fence to do it. Breaking the driving protocol, but we're going to do what we need to do based on the circumstances. A good therapist is 100% comfortably competent. I use the term comfortably competent to say it's even unconscious. They know the clinical protocol so well that it's not a question of knowing it when they veer. It's a matter of a conscious decision to say, I need to do something different for days of years based on what's happening in this moment. And they do it consciously, and they end up, and actually they get better results doing that than somebody that's adhering to the protocol 100% of the time.
Yeah. When we spoke about this, I think I used the term situational innovation, or perhaps you used it. I don't recall, which I think is a fairly decent way to describe that other 15%, the zigs and zags.
Yeah, I think it is too.
So how do you assess that? Can you assess it? I know, for instance, there are situational judgment tests that people take.
Yeah, so it's a good question. I don't know I have an answer to that. I just know that the first step in that is getting people absolutely comfortably competent with the evidence-based practices that are most likely to create the best and quickest clinical outcomes for the person that's sitting across the chair from them. So that's where we're at right now. I'm sure there are assessment skills that surveys, but remember, we're monitoring both clinical outcomes as well as benchmarking fidelity. So there's with the technology today, this opens up a whole series of opportunities, not only for advanced clinical training for our clinicians, but also insights into patient populations that may or may not respond as well to the evidence-based practices. We're beginning to understand a little bit about that zigging and zagging. I mean, what is happening inside that 15% variance? If there is a 15% variance for each patient. So there's a whole series of, I think, really good research questions that we haven't even thought to ask yet because it hasn't been possible to answer some of the questions that we're answering today.
We touched on AI a couple times in this conversation, partly with the work with your partnership with Listen and some other aspects. And as you know, no conversation these days is complete without touching on AI. And I think in this field, it's a particularly important and even delicate conversation to have because generally speaking, you have that dilemma, the ongoing dilemma. How do you balance AI and the human element? I think it's particularly a sensitive conversation in the work that Centerstone and now Centerstone and Brightli do. So what's your position on that? What are your thoughts on that?
Well, it's definitely here to stay. It is likely to be the most transformative development, certainly in our lifetime, and we certainly had many. And there are folks that say much more than that. It's going to be it's going to change the world in ways that I don't think we can fully understand yet. There are benefits to it, and there are certainly risks. I know when we first started looking into AI, and we've got a number of AI partnerships, there weren't standards. And I was really pleased that our compliance office and our institute got together just spontaneously on them. It didn't come from me, and began thinking through and developing some standards for us. We see such variance across the country right now. There are some states that have got enormous prohibitions against any kind of AI use, even in the area of training. It's an absolutely game ender. There are other states for which there are virtually no regulation at all. It's why, for us, the way in which Listen developed its technology ended up being hugely important to us. That this is a curated AI. This is not open source coming up with dangerous advice. And also our AI interfaces with our clinicians, not with our patients. So you've got a human at the wheel, if you will. So those are important to us at this point. The other is making sure that the privacy and security is there. We don't hold on to the AI ambient listening for long periods of time, just long enough to get the clinicians the feedback they need and so forth, and to be able to capture some of the insights, but not maintain anything that would in any way compromise the privacy of the individual. So and we're very careful about vetting our partners in terms of their security protocols. So I think the big risk that we've already seen happen in other entities is where they start opening up the AI application to patients. And you've heard the horror stories of
Yes.
individuals being given guidance on how to take their life, for instance, by an AI technology. So, I get asked all the time, Charles, are we going to see AI take the place of clinicians? And I say, I don't see that anytime soon for a couple of reasons. But the first is this: you need to have a human interfacing between that for just the safety and security of the patient. And the other is people people that are seeking care crave the human connection. And I think down the road there's certainly going to be tools that help us, patient help tools that are powered by AI, and we see a lot of them right now, but emerging. But I think the clinical relationship is, as far as I can see it, is going to be here for a great length of time.
David, this has been a terrific, wide-ranging conversation. I, of course, expected no less. And I have to say, again, you're leaving quite a remarkable legacy, but you still have about another year and a half to go. I don't want you to get too comfortable. It's a lot of work ahead of you.
Trust me, there's nothing comfortable right now. It's, we all talk about the fact everybody is smiling at each other, but tongues are hanging out. There's a lot of work right now, but I'm just so grateful for the team and the boards. I mean, we're on it for the same reason. So people are just hunkered down, working really hard and supporting each other. Thank you for having me on the podcast, and would love to come back sometime.
Absolutely. But I was about to say, I wanted to wish you the best of luck with your beloved Vanderbilt football
Yeah, thank you.
team.
Anchor down.
Yes, I know that's very important.
Thank you, Charles.
Thanks so much, David.
Take care. All right. Bye-bye.
Today, I spoke with David Guth, the Chief Executive Officer at Centerstone, a nonprofit health system specializing in mental health and substance use disorder treatments. This is Charles Epstein for the Catalyst Podcast. Thanks for listening.